Nu weer, maar ik was opeens ging eruit.
Oké. Nou, hopelijk blijft het goed gaan.
Hallie.
We will start in 1 minute. Hereby, I open this academic ceremony in which Lily will defend the academic thesis, Platelets in Thrombosis and Haemostasis, Synergy with Thrombin Generation. I'd like to welcome everybody, of course, the candidate, Lily, the supervising team, Professor Tekate and Drs. Roest and Huskens, and the members of the degree committee, who I will introduce later on. But first of all, I would like to invite Lily to present a summary of your study and the conclusions of your thesis.
Thank you, Prorector. I'll start sharing my screen. Can you see it? Dear Prorector, yeah. Dear Prorector, dear members of Corona, dear family audience, in the coming 15 minutes, I will present a summary on my thesis entitled Platelets in Thrombosis and Haemostasis, Synergy with Thrombin Generation. First, I'll start by some background information about hemostasis. Hemostasis is a cessation of blood loss from a damaged vessel. It is accomplished by a complex set of reactions that includes both cellular components and proteins in blood, all working together to form a hemostatic plug, which can be considered as platelet plug embedded within a cross-linked fibrin mesh. And my thesis touches on two topics in hemostasis. The first is about platelet response, which can be roughly dissected into adhesion, activation, and aggregation. And the other topic I touches on is coagulation, or to be exact, the procoagulant pathways, which lead to the formation of fibrin, which is a key enzyme that cleaves fibrinogen to fibrin. And both these topics closely interact with each other and making them more efficient than the process separately. And also abnormalities in either platelet function or in coagulation factors will cause a hypocoagulable stage, which may cause bleeding, or a hypercoagulable stage, which may promote the formation of venous or arterial thrombosis. Then in my thesis, to investigate platelet, we used whole blood platelet activation test, whole blood PACT in short. As shown here, after activation by agonists, platelets will release P-selectin from alpha granules, and also alpha-2 beta-3 will change to its active conformation, facilitating the binding to fibrinogen. So active alpha-2 beta-3 and platelet surface P-selectin can be chosen as platelet activation markers and then quantified by fluorochrome-labeled antibodies and then detected by flow cytometry. In the meantime, upon platelet activation, they can form complexes with monocytes, either by P-selectin with PSGL1 by monocytes, and also GP1B alpha with MAC1. Because the circulating degranulated platelets can rapidly lose their surface P-selectin, So we use the platelet monocyte complexes, PMCs in short, to measure platelet activation level by flow cytometry. And then to measure coagulation, we mainly used thrombin generation experiments. And as showed here, this is a typical curve of thrombin generation done in plasma, either platelet poor plasma with phospholipids or platelet-rich plasma. The lag time and time to peak indicate how fast the thrombin is formed, and peak and ATP indicate how much thrombin is formed. In the meantime, with an assay optimized in our lab, we also did thrombin generation in whole blood, and the parameters are almost the same as the previous curve. However, the thrombin generation potential is indicated by ATP anterior peak. So after all this background information, I will start to talk about the individual chapters of my thesis, starting from the first part of my thesis, which focuses on platelets and thrombin generation. It was reported that collagen can initiate thrombin generation by activating factor 12. And as showed here, in platelet-poor plasma, collagen's effect in thrombin generation can be completely blocked by CTI, which is a factor 12A inhibitor. However, in the presence of platelets in PRP, CTI can block TG triggered by collagen. And this may indicate that platelets activation by collagen may play a role in thrombin generation in PRP. Then we also found out that platelet activation by specific GP6 agonist, CRP-XL, also initiate TG. So we wondered how, and we did some experiment and found out that factor 7AI or anti-factor 7 antibody only showed a mild impact. And by doing thrombin generation experiments with different factor division plasmas with virtual platelets, we found out that TG was impaired in only factor 9 or factor 8 division plasmas. And this information gave us a clue to set up a purified system, which is comprised of different coagulation factors with or without virtual platelets, with or without agonists. And then we detect 10A generation in this purified system. And mainly we have 3 different combinations of coagulation factors. The first is factor 8 with factor 10, and then factor 9 with factor 10, and then factor 10 alone. And we only with the combination of factor 10 and factor 8, we found out a significant increase in 10A generation, which indicates 9A activity coming from GP6 activated platelets. And then by applying the anti-9 antibody, we found out an inhibition in both 10A generation and thrombin generation experiments. And also we found out with actual factor 8 added, the TG was recovered in the factor 9 division plasma. So all this data suggests GP6 activated platelets can initiate TG while platelet-derived 9A activity. Later on, we did 2 clinical studies in patients with increased thrombosis risk. The first we did is in patients with in multiple myeloma patients. These patients are on chemotherapy and immune therapy and are reported to have increased venous thrombosis risk. Despite that, they also have a high prevalence of thrombocytopenia and anemia. So we did a case control study by including 21 multiple myeloma patients with 21 healthy controls. And we found out, despite no significant difference on plasma TG, we found out these patients showed a delayed initiation and longer time to peak in whole blood thrombin generation. Also, they showed increased thrombin generation potential. Also, in these patients, their platelets have their platelets displayed diminished reactivity, especially indicated by the lower alpha-2b beta-3 activation capacity. So this data may help us to understand the disbalanced hemostasis profile of these multiple myeloma patients. Next, we did a study in patients with COPD. COPD patients following acute exacerbations are reported to have increased thrombotic events. And this is hypothesized by that acute exacerbations are related with increased systemic inflammation, and increased systemic inflammation can drive coagulation. So we did a prospective study by including 32 COPD patients and collected blood samples at 3 time points. The first is at admission, and it's considered as ACOPD, and then day 3 of treatment, and then convalescence. We found out there was no increased platelet reactivity during 3 time points. However, we saw an increased platelet monocyte complexes formation, which indicate a higher platelet activation during ACOPD. Later on, we also found out that these patients during acute exacerbations have increased peak and ATP on their plasma thrombin generation. However, there was no difference on lag time. Furthermore, we found out there were some positive correlations between plasma TG and inflammation marker C-reactive protein. So done with the first part of my thesis, I will start talking about the second part of my thesis, which focuses on platelet function, or to be exact, the clinical application of whole blood pact. As discussed in the beginning, we used a whole blood pact to detect platelet reactivity, while LTA, a light transmission aggregometry, is still the most commonly used test and considered as the standard one. So we compared both tests in 2 populations by setting up cutoff values and scoring systems. The first study we did was in 42 patients on dual antiplatelet therapy, and we compared both tests to detect high residual platelet reactivity by using ADP trigger LTA and mass ADP trigger whole blood pact, and we found out a moderate agreement between these 2 tests with a kappa value of 0.6. Then we also did a study in 161 patients with a suspected bleeding diathesis. By using the scoring system, we found out a moderate correlation between 2 total scores. And furthermore, whole blood pact even recognized more patients with elevated bleeding score. So altogether, these data suggest the added value of whole blood pact in platelet function testing. Then in summary, my thesis presents the findings below. First, platelets activated by GP6 initiate TGY9 activity, and multiple myeloma patients on treatment have a disbalanced whole blood thrombin generation profile, and ACOPD is associated with increased platelet monocyte complexes and plasmatic coagulation. In the second part, we show that whole blood pact has a moderate agreement with LTA for patients on DAPT, and it has added value for recognizing thrombocytopathy. In the end, I'd like to thank you for your attention, and I give the word back to the prorector.
Thank you very much for your presentation. The opposition will be opened by Professor Henskens. Professor Henskens was chair of the assessment committee, and she's professor of clinical chemistry at Maastricht University. Professor Henskens.
Thank you. Dear candidate, I would like to congratulate you and your team for this thesis. I've been reading it with interest since you describe several diagnostic tests to measure the function of coagulation and platelets. And at this right moment, your thesis is of special interest for me since I'm participating in the next guideline for diagnostic tests and platelet disorders. And flow cytometry by using activation is one of the techniques under discussion. So should we add it to our guideline? We are not convinced yet. Therefore, I would like to discuss a few issues with you on chapters 5 and 6. And first, I would like to start a sort of general discussion with you, because you mentioned in your introduction and at the end that there are several advantages of flow cytometry of platelets after activation. But in the introduction and also at the end, you always focus on patients with a low platelet count. But that's only a very small number of our patients in the daily clinic. So in the Netherlands, LTA is still the golden standard. Only 2 or 3 labs in the Netherlands use the activation test. And what is, in your opinion, and looking at your research, the most convincing advantage why we should change our strategy and go to flow cytometry?
Highly esteemed opponent, thank you for your question. For considering flow cytometry as adding to the guideline for platelet function testing, I think it's still probably at this moment it's still not a very good idea to include it. I think based on my understanding, it is still on the researching state, and as you mentioned, patients with low platelet count doesn't count that much in the whole population. For me, I think then the biggest advantage for flow cytometry is that it can be applied in neonatal samples, because, for example, LTA needs a lot of amount of blood to prepare for PPP or PRP, while whole blood packed, they only need several drops of blood. So I think the blood volume is a big advantage over here. And then I think if we consider to any test for a diagnostic test, probably we will consider what kind of occasion it can be applied. So as I remember that, for example, if you take platelet function defect, mild platelet function defect as an example, then probably you have first a screening test, and then you go step by step to have a more clear diagnosis to get more clear answer for what really causes this symptom. So I think probably flow cytometry still, I think, is behind LTA.
Okay.
And for me, I think, yeah.
Yeah, thank you. I think your answer is very honest. And I think that we have to work on it further, and then it would be a serious candidate. So I want to go further on chapter 6, because on page 101, figure 1, I am very interested in your score system. And you explain your score system in this figure. And a score system could really help us, not only for flow cytometry, but also for LTA, to standardize results. But I was thinking, how did you choose by giving scores on the left to the flow cytometry? You did it based on, I think, the confidence intervals. And on the right, you gave the LTA scores based on mostly maximal aggregation. And I don't see any input of a healthy volunteer confidence interval in that section. So I was wondering, in the Netherlands, we say, are you comparing apples with pears here in your separate study designs? Because, for example, you give 2 points to patients, or 1 or 2 points, and these results could also be found in normal, healthy volunteers, if I understand it well. So please, can you explain me, why did you choose these 2 score systems?
Well, actually, we did not choose these 2 scoring systems. For example, for whole blood packed, this scoring system is setting up by us. And for LTA, I think we just use this one. I mean, the certain score for each parameter, for example, maximal aggregation, disaggregation, or increased lag time, was just, I think, was achieved by discussion with a collaborator in hand. And actually, I think this is not standard. So I partly agree with your comparing pear or apples. Yeah.
Okay. So maybe why I was saying it, because maybe flow cytometry is even better or even worse than we thought if we use the same score systems. But still, I think it's interesting to use a score. but then I want to go further on this because I don't know whether you are familiar with that, but if you go to page 104, you made this score correlation graph, figure 4. And what we see then is that there are indeed patients with a score 0 on the flow cytometer, and they have a high score on LTA, and the opposite around. And I was wondering there, because in LTA, we sometimes say that when a patient only has an epinephrine aberration, then it does not count for the diagnosis because it's an agonist which is weak, and it's sometimes also very variable in a patient. So in our clinic, when the patient only has an aberration on epinephrine, we don't count it as a disease. Was that also used in your score system, or did every aberration count?
To answer your question, I have got several ideas. The first is if we are going back to page 101, and then you can see we actually have different agonist panels for whole blood pact and LTA. For example, there are, epinephrine was not included, and thromboxane A2 was not included in our whole blood pact. And also instead, for example, we have CRP instead of collagen in LTA. And also we have TRAP for PAR1 agonist. So actually, and also if you compare the number of agonists used in different tests, whole blood pact, we have 5 agonists. And then for LTA, we have 8 or more. And then, so actually the scoring by either whole blood pact and LTA cannot be directly compared. As you can see, for example, there are some patients maybe score 0, and then he or she may show a positive value on the other test because we used actually a different agonist panel. And then I think for this may explain part of the difference over here.
Okay.
And then, yeah.
So maybe the score system and the difference in the scores could also be a part of the difference that we find at the end, because you show in your figure 5 that the combination of both tests will detect the most patients, and that there are differences between the 2 tests. Which brings me, when flow cytometry would be in the guideline, should we then start with flow cytometry or start with LTA, or do them immediately both? Which makes our healthcare even more expensive.
Short answer, please.
Okay, I agree. It will make the both tests are expensive, and I think I would prefer LTA first.
Okay, thank you very much. I give my word back to the record.
Thank you very much. The opposition will be continued by Professor Heemskerk. Professor Heemskerk was also a member of the assessment committee. He's professor of cell biochemistry of thrombosis and hemostasis at Maastricht University. Professor Heemskerk.
Dear candidate, also my congratulations for this very nice thesis. You wrote 8 chapters, 6 of them of experimental work on relevant aspects of platelets and coagulation and for factor. So there's an interesting triangle of processes that really control the hemostasis and thrombosis. And my congratulations also extend to your supervisory team who helped you to complete your PhD study with this thesis. Before detailing on specific questions, I would first like to go to the very first page, actually the outside of the cover of your thesis. And I have a question on the title. So I understand the first title, but then I find it in some way complex to combine that with the subtitle, synergy with thrombus generation. Do you mean with this term synergy with thrombin generation, that thrombin generation is the same as coagulation or is controlling coagulation. So why did you include thrombin generation in the subtitle and not coagulation?
Highly esteemed opponent, thank you for your kind words and question. For your question, why I include thrombin generation instead of coagulation, I think it is because actually I mainly use the thrombin generation to measure coagulation in my thesis, and I haven't used the other methods. And also, thrombin generation is, I think, is the most it's a test I did the most during my PhD.
Okay, so that's practical, but what is your personal opinion? Is thrombin generation a good estimate for the coagulation process, or because we miss fibrin, or should actually fibrin be measured instead of thrombin generation?
Yes, I agree. If to really measure coagulation, there are quite a lot of aspects, and for example, fibrin information is an essential one also, and I think probably if saying, but if we take one step back, I think thrombin is a key enzyme that cleaves fibrinogen to fibrin. So I think it has its special role.
Yeah, I agree. Yeah, I agree with you, especially because I want now to go to chapter 2, especially, let's say, to look at the role, potential role of factor 9. Of course, it is much more evident, much more straightforward to look at thrombin generation than at fibrin generation. But I also have a question on the title of chapter 2. You put a question mark there. What does the question mark mean? Are you not sure about the role of factor 9 there? The title of chapter 2 contains a question mark.
Yes, actually, I'm not sure about factor 9's presence inside platelets. I think my results show that there was 9A activity, but I'm not sure about whether it's 9 or 9 with its activator. Okay, so we use the question mark.
Okay, so it might be, in your opinion, it might be either 9 or 9A. Okay, that explains because
no 9 or 9A, but 9A or with 9 with its activator, we don't know.
Okay, so there is a role of factor 9, 9A. I agree with that. But for specific question, I would like to go to figure 2. What strikes me there is, of course, now I'm quite interested in GP6. What strikes me there, if you look at the thrombin generation curves in figure 2, actually panel 2B, with platelet-rich plasma, there is, of course, an enhancement by stimulating GP6 with CRP. There's also a further enhancement if you stimulate alpha-2 beta-1 with GFO-GR. But still, if I look at those curves, it's not the same as collagen. I mean, the combination of CRP and GFO-GR seems to be not as strong as collagen stimulation. So actually, what are we missing there? What?
As far as I remember, that collagen can initiate factor 12. Initiate thrombin generation while activating factor 12. And I thought it directly binds with factor 12, and I think this might not be related with any platelet activation. So I think what CRP-XL or GFO-G miss here is that they cannot directly bind with factor 12, and then without factor 12 activation here in PRP, we cannot see such a strong effect as collagen.
Okay, I completely agree with this. Which, by the way, which collagen have you been using? Which
collagen 1.
Collagen 1, home collagen. So collagen is not a very strong activator of GP6, while CRP is a very strong activator of GP6. So it might be possible that the missing part, which could be factor 12, is quite relevant, let's say, in seeing the effects that you described. Would you agree that there is extra synergy with factor 12? Probably, and that maybe the factor 9 dependency also depends on the intrinsic coagulation system? I mean, it's a complex question. So if the dependency of factor 9 that you see, could that potentially depend on factor 12?
I would not. I would say no.
Why?
As because for example, if I consider experiments done later, for example, in factor 12 deficient plasmas, and with CRP XL, I don't see any decrease in thrombin generation, and I think this factor 9. I mean, if your question is the factor 9 dependency is related with factor 12, it's not. It doesn't work over there.
Mm-hmm. Yeah, I see a point. I mean, you have a few experiments that really point to factor 12 independent part. But an offside question is: have you ever performed experiments like in Figure 1, where you combined factor 7, inactive factor 7, together with CTI? So have you performed thrombin generation experiment where you blocked both the intrinsic pathway with tissue factor pathway and the 12 pathway? Have you ever done that?
Yes.
Is there residual thrombin generation if you block collagen-induced thrombin generation if you block both factor 12 and both factor 7?
Yes.
So there is something.
Could I ask you to repeat your question again? I
Yeah,
think
so
we agree on the.
Yeah, so the question is, let's say, in the conventional coagulation, we think that there's two pathways to trigger. Eh? One trigger is tissue factor 7 pathway, and the other trigger is factor 12,
yes.
The intrinsic pathway. So my question is, have you done thrombin generation experiments where you both inactivated tissue factor and
yes.
inactivated factor 12?
Yes, we did that, and that is shown in Figure 1D. Mm-hmm. So we did use the CTI with factor 7 AI or CDI with anti-7 antibody.
Okay, that is collagen triggered, but have you also done that with CRP, GFO?
We also did, yeah, we also did, but we didn't show the data, yeah.
Okay, and that is your argument that there's a factor 9 activation pathway independent of tissue factor and independent of factor 12.
Yes.
Okay, so that is very nice, very clear. However, there is one small problem, and that if you look at the platelet proteome or the platelet transcriptome, you cannot find factor 9.
Yes.
And in addition, endothelial cells contain binding site for factor 9. The platelets so far do not contain binding sites for factor 9. So it's also unclear, let's say, how factor 9 could be internalized. So what is your idea about that mechanism of how is the factor 9 internalized into platelets when it's not expressed on an mRNA or protein level?
First, I think I question about the results we have about the transcriptome about platelets at the moment, because I think with different isolation of platelets, different isolation methods of platelets, you can gain quite different results on the transcriptome profile. This is first, and then for example, if really considering how or why those non-activity from platelets, then I think about basically two ways. The first is it can be endocytosed by platelets, and either it can be, for example, it can come from megakaryocytes. And then I'm not sure about megakaryocytes, the proteins in them. And then, for example, considering the binding sites you mentioned before, I think I'm not sure about receptors. Probably you mean receptors. There are not receptors for factor 9 on platelets, while I'm not sure about phospholipids that could bind to factor 9. Even though it might seem that platelets need to be activated and they can express for negative charge of phospholipids. However, I think they may contain a certain part, a certain amount. For example, apoptotic platelets may take this role. And so actually, coming to the other idea, that is
Can you
probably
try to
that
give
is
a short answer?
okay. Probably that is not 9A. It could be something that could activate factor 9 or other things, because we cannot show actually the presence of it.
Okay, I'm quite satisfied with the answer. I give the word back to the poet.
Thank you, Professor Heemskerk. The opposition will be continued by Professor Lisman, also a member of the assessment committee. Professor Lisman is professor of experimental surgery at University Medical Center in Groningen. Welcome, Professor Lisman, the floor is yours.
Thank you. Dear Madam Candidate, also I would like to congratulate you with your thesis, which I read with a lot of interest. Also, I would like to congratulate your supervisory team. As you will notice in this entire defense ceremony, this committee is particularly intrigued by your chapter 2. So I will continue where Professor Heemskerk left off and ask a couple of more questions, because what you're showing is a very new mechanism, which is somewhat provocative, and I want to discuss a few details also with you. So to start with, at the very end of this chapter in the discussion on page 37, you basically end your work by saying we need to further establish whether this work has clinical implications. And my first question regards these clinical applications, or maybe even physiological implications. So what you're showing is that there is a pathway of activation of coagulation that is independent of tissue factor and independent of contact activation that can be triggered by collagen. But can you just help me out? Can you think of a situation in physiology or pathophysiology in which there's no tissue factor exposed to the blood, in which there's no chance for the contact system to be activated, in which this mechanism you show could be relevant?
Highly esteemed opponent, thank you for your kind words and for your question. If let me think about a situation that there's no tissue factor, I would think about the knee for any joint tissues. So probably there's no tissue factor over there. And then for other pathological occasions, I would think about, actually it will still focus on platelets, and I don't have a good idea on this part.
So I agree with you that there are parts in the body where there would be little or perhaps even no tissue factor, even after tissue injury. And I agree that knees or joints would be nice candidates. But why wouldn't there be contact activation in those cases?
So you are asking why knees and joints don't have contact activation over there?
Well, yeah, to get an idea of when this 9A initiated thrombin generation would be relevant. So
I think actually I partly agree what you want to say. That is probably, even though this mechanism works, but in actually physiological conditions, it cannot have its effect, because, for example, tissue factor or any contact activation can take place already.
Right, and yeah, and so my second question, because I still think, I mean, your experiments are convincing, so I'm not dismissing what you're finding, but I'm just trying to understand under what conditions this might occur. But when I think about this, I have a next problem. So you're saying, well, there's either 9A in platelets that is released, or there's 9 activation within platelets, and then 9A comes out. But besides 9 or 9A in platelets, there's also at least one inhibitor of factor 9A, which is protease nexin 2. So there's also an inhibitor of factor 9A present in platelets. So if both enzyme and inhibitor come out, why would there be activation of coagulation? Why would the enzyme win from the inhibitor?
Well, I cannot answer this question because I haven't done any experiments regarding Nexin 2. And also, actually, when we were doing the experiment, we thought about the possibility on Nexin 2, and we thought about the decrease on Nexin 2 or any effect on this, because that was another possibility that there was only 9 binding to activated platelets. Other than the release of 9 or 9A coming from platelets, there was also plasma 9 binding to platelets. That is also another possibility that we thought about.
Right.
And then we also thought about Nexin 2, yeah. But we don't have an answer on that.
Okay. So then my next question will be about an experiment you have performed, which is in figure 1 of this chapter. And then so you compare a platelet poor with platelet rich plasma, and then you activate platelet poor plasma with collagen, and you actually see quite robust thrombin generation, which is in line with literature that as you mentioned before, collagen can bind and activate factor 12. And then in platelet rich plasma, this pathway seems to be no longer relevant, because here CTI hardly inhibits collagen-induced thrombin generation. And so you say that this is because then your 9A pathway becomes activated. But wouldn't you still expect some effect of CTI? So there's such robust activation of coagulation in the absence of platelets by collagen in figure 1A. Why doesn't collagen-induced 12 activation no longer occurs when there's platelets around? Or am I misinterpreting that figure?
For me, I think in figure 2B, that's still an inhibition of CTI, which indicates that the 12A activation by CTI still take place in PRP. However, I think if we imagine that probably there was several mechanisms competing with each other, and several one may take the first place. And then, for example, because I think if we consider the experiment I did in PRP, that is, I think the platelet activation by collagen can take place quite fast. However, it may indicate that the activation of collagen in plasma, I mean, the direct interaction between collagen and factor 12 may be at a later stage. Just a wild guess.
Okay. Is there time for a last question?
Yeah,
Okay.
a short question. Answer.
A short question. So you mentioned in the discussion results by Koen Maas from Utrecht, who showed polyphosphate excreted from platelets after platelet activation. So he shows that platelet polyphosphate activates a contact activation in platelets under conditions of flow. And in your experiments, you state there's no role at all for polyphosphate-induced contact activation. So can you harmonize these findings? So why don't you, in your experiments, don't observe those platelet polyphosphate-induced activation of coagulation?
So do you mean what kind of experiments that led me to think that there was no role of poly-P in my experiments?
Yes.
So
what's the difference?
The difference is, I think, because in our system, in PRP environment, I think poly-P, there was several possibilities. That is short chain poly-P or medium chain poly-P coming from platelets. But normally it was, I think in literature, it was reported that they had to get dense, then form as a something like a surface, like a contact activation pathway that still acts factor 12, then promotes thrombin generation. So I think either these conditions are not applied in my PRP environment.
Okay, thanks very much. I thank you very much for discussing with me, and I give the word back to the rector.
Thank you very much, Professor Lisman. The opposition will be continued by Dr. Koene. Dr. Koene was also a member of the assessment committee, and he's from Maastricht University. Dr. Koene.
Thank you, Pro-Rector. I have only to agree with the other members of the committee and the other opponents. I really enjoyed reading your thesis, and I really thought that, and still think that your data are very interesting. And I would also like to congratulate your supervising committee. So I have, for a change, a question on chapter 4, and I'm very interested also in monocytes and other leukocytes and the interaction of platelets with other cells in the body. So this is actually a chapter that really aroused my interest. And you have written in the introduction a small piece on platelet monocyte interactions. Could you please very briefly summarize which platelet and especially also which monocyte receptors are involved in this interaction between platelets and monocytes?
Well, I think the first one would be PSGO1 that binds with P-selectin on platelets, and the second would be MAC1,
yeah,
and then which binds with DP1B alpha. These are the two main receptors on, on monocytes.
Yeah, and then you probably also know that these interactions are metal ion dependent, and this is where my question comes in. Because metal ions are really important for the P-selectin and also other selectin interactions with their ligands. And there's also magnesium. Calcium is inhibiting actually with the integrins, but magnesium is actually essential also for binding to its ligands. And when I was reading your message section, I got a little shocked because you actually took the blood samples in anticoagulants that were chelators, so EDTA and also citrate, which actually very effectively capture away these divalent ions and then practically inhibit the function of the integrins and the selectins. So in my hands, when I treat my platelet monocyte complexes with EDTA, then they fall apart. So my question is, doesn't the use of this anticoagulant actually lead to an underestimation of the platelet monocyte complexes that are present in blood of these COPD patients?
Esteemed opponent, thank you for your question. I agree with your idea that, for example, these ions would be important for the complexes. And in our experiment, we actually used saturated blood, not EDTA. EDTA was only for the blood count part. And actually, we also have seen that with EDTA tubes that we have underestimated platelet monocyte complexes.
So you can measure them, and I'm a bit relieved because EDTA is much worse than citrate.
Yes, so, it's much worse. So we chose saturated blood tubes.
Very good. So then I come to your statement, because you write in the introduction on page 15 and also in the discussion of chapter 4, page 78, I read it. PMC formation may be a more sensitive marker of platelet activation, as circulating platelets rapidly shed surface P-selectin, but continue to circulate in complex with monocytes. Which is, I think, an interesting statement, and I would like to challenge it a little bit. Because what do we know about turnover of platelet monocyte complexes in the body? How long do they circulate? Can you tell me a little bit about it? Is there something known about it?
I don't have much knowledge on this. I think it will depend on the macrophages, how they destroy these complexes, and mainly it may depend on the activation level of monocytes.
Okay.
Just a guess. Yeah.
Yeah, I was hoping that you would say no, or at least not much, because I actually do. There's a paper from 2003 in mice actually showing that if you inject activated platelets into mice, then they bind very quickly to leukocytes, so neutrophils, and also monocytes. And then after they bind, they completely disappear within 5 minutes. And then the monocytes reappear again, naked, so without the platelets attached. So I think we're not completely ready with answering the question, what is the therapy? So what is the predictive use? At least humans may be different than mice in this respect. And we see it also in acute cardiac events that we see an increase of platelet monocyte complexes. So I also believe in them, but this is something that I wanted to show you. And I think that platelet monocyte complexes might just be as short-lived as p-selectin on the surface of circulating platelets. But still, and I think you gave me a very nice introduction on platelet monocyte interaction. There are also other binding partners. Can you mention me maybe also one or two other binding partners that might be involved in platelet leukocyte interaction?
I don't have a clear memory. I think platelet alpha 2 beta 3 is also involved.
Yeah, well, at least it sometimes look like that's indeed the case. But there's also CD40 ligand on platelets and MAC1 then again on macrophages. And I was a little bit intrigued by MAC1 because I couldn't read it from the methods, but there are a couple of very interesting, also commercially available antibodies for MAC1 that measure activation state of MAC1. And to my best knowledge, you only measured expression. So my question to you is, what results would you get if we would use a MAC1 activation state antibody in these patients? Would it be different?
I think it will depend because, for example, I think this is the same issue with for example, we measure p-selectin at the same time we also measure PMC formation, because if you consider the formation of platelet monocyte complexes, MAC1 is involved. I mean, active MAC1 may be involved. I'm not sure whether this formation requires the active form of MAC, but if it is so, then some part of the active MAC would be assumed by the complexes and cannot be detected anymore. Mm-hmm. On the other hand, I'm not sure also, for example, as you said, if we consider, for example, a von Willebrand factor with active von Willebrand factor, and these are also most of the times quite different, because and then this would be the same situation here. For example, these monocytes have MAC1, and also part of them have active MAC1 on their surface. So I don't have a clear answer for this.
Okay, thank you. I'm satisfied anyway, and I see the pro-rector nodding. So I think my time is up, and I give the word back to the pro-rector. Thank you very much.
Thank you. The last opponent will be Dr. Spronk. Dr. Spronk is from Maastricht University as well. The floor is yours, Dr. Spronk.
Thank you, Pro-Rector. Dear candidate, dear Lee, I can only follow in line what my colleagues already mentioned. Congratulations with this nice thesis with a lot of extensive work in it. And I also would like to congratulate your supervisory team. given the time, I skip my complete introduction on your introduction and the outline of your thesis, where I thought there are some flaws in it. I will skip that, and I would like to ask you to read proposition number 7.
Esteemed opponent, thank you for your question. And proposition number 7 is thrombosis is not hemostasis gone bad.
Thank you for that. I was a little bit flabbergasted by that statement. I am already an old guy, or at least sometimes I feel an old guy, and I'm trained with Virchow, the triangle of Virchow, that either one of the components in blood vessel wall or flow will change, leading to either bleeding or thrombosis. I am trained by the hemostatic balance. There is a balance, and if that balance tips to one side, you get a bleeding. If it tips to the other side, you get thrombosis. And then following the book Platelets 4, I read the chapter, and following your statement, they state that it's not to imply that hemostasis is always good and thrombosis is always bad. So my first question is, if you follow this proposition and you agree with this proposition, do you then agree with the second proposition in that chapter, that hemostasis could sometimes be bad and that thrombosis could sometimes be good? My question would be, when would thrombosis be good and when would hemostasis be bad? That's my first question. And the second question is, if this whole balance idea is incorrect, how can thrombosis then not be hemostasis gone bad? Then you could also argue that bleeding is also not hemostasis gone bad. But if I see a factor 8 deficient subject or a factor 9 deficient subject, they really feel bad with their wrong hemostasis. So what do I miss in my reasoning, or is your proposition wrong?
Thank you for your question. I think for the first one about hemostasis is not always good and thrombosis is not always bad, I think I partly agree with your idea. Because I cannot find an opposite example to go against this. To really think that hemostasis can be bad and thrombosis can be good. And then coming to your second question, actually, personally, I agree that, or I would prefer Virchow's trial than the balance of hemostasis in between of bleeding and thrombosis. That is to say that I think the direct opposite of hemostasis is bleeding. And I think, for example, as you mentioned, factor 8 or factor 9 deficient patients, they have quite some bleeding symptoms, and these are not very good things. While I think, and also going to the proposition here, that is, I think they emphasize on the word gone, because they think probably thrombosis and hemostasis are initiated quite differently. And for example, as they mentioned, hemostasis is really started by a breach in the vessel wall and a pressure drop. And then a plug has to be formed to prevent further bleeding. While thrombosis, for example, if you take arterial thrombosis as an example, it really starts from atherosclerotic rupture, and then it blocks the vessel. So these, I think, for example, if we consider thrombotic plug and hemostatic plug, they have quite different structures and they are initiated quite differently. So I think that's the reason why I chose this proposition, is for me to remind myself that thrombosis, for example, there are quite some same participants in both hemostasis and thrombosis. However, I think they are still quite different.
Okay, thank you for that. But and I'm happy that you mentioned the breach in the vessel wall leading to hemostasis, and then you continue saying that the atherosclerotic lesion that ruptures leads to thrombosis. Isn't the rupture of the vessel wall, not the breach in the vessel wall, and thereby a general breach comparable to the rupture of the atherosclerotic lesion, which is also a breach. And thereby thrombosis is the bad guy of hemostasis.
I think I don't have much knowledge on this. While, for example, if you consider the usual, for example, a cut you have in your vessel, and then, for example, then the endothelial substances would be exposed. However, consider arterial thrombosis and these atherosclerotic rupture. I think they are quite different, and because these these foam cells and this rupture mainly develops. These are already a pathological condition.
If I may help you a little bit, if you stab someone with a knife, you get a breach in the vessel wall. You get rupture of the endothelial layer. If you perform an atherosclerotic lesion, you make a disruption in the endothelial barrier. What's the difference? In both cases, the endothelial barrier is damaged. I don't see any difference. Do you? Thank you very much. I give the word back to the pro-rector.
Thank you very much. Lily, the time appointed for defending your thesis has passed. The degree committee will now withdraw to discuss the quality of your thesis and your defense. I request that you and your company await the results of our deliberations and our return. The degree committee here present online has assessed the quality of your thesis and your defense. And in view of its positive verdict and taking into account your previous qualifications, the degree committee has decided to grant you the degree of doctor. Professor ten Kate is authorized to confer upon you this academic distinction in accordance with Dutch university custom. I invite your supervisor to now take the floor.
Thank you, Mrs. Pro-Rector. The candidate starts with a promise. Do you promise to work in accordance with the principles of scientific integrity at all times, to be careful and honest, transparent, independent, and responsible?
Yes, I promise.
Thank you. By the authority vested in us by law and in conformity with the decision of the committee here present online, I hereby confer upon you, Lily, the degree of doctor and grant you all rights attached by custom and law. As evidence of this, you will soon receive the degree certificate signed by the rector, the secretary, and the supervisor, affixed with the official seal of the university, shown now by the beadle. Congratulations, Lee. You did very, very well. You can be proud of yourself. But otherwise, I give the word to Dr. Huskens for the laudatio.
Thank you.
Dear Dr. Lee, I will start from the beginning. December 2016, Mark had a Skype conference with a Chinese PhD candidate called Lily. At that time, we did not figure out that your first name was just Lee. I'm sorry for that. Mark was really impressed by your CV and your fluency in English and offered you the position. However, you hesitated and asked for more time to read all our research proposals. In February, if I'm not mistaken, you first turned down his offer. And then he got an email that you could not make up your mind at first, but then you decided that you did want to seize the opportunity. If I look back at the reaction, it does not surprise me. You are very intelligent and I admire your well-considered way of working, but you are also not always that self-assured, and sometimes you lack a bit of enthusiasm. When you started at Synapse in October 2017, I was excited. You were the first PhD student that I would supervise. You made a really good impression by working hard, and also it was easy to communicate with you. The project you would work on was clear, and you made a flying start with introducing a new technique in the lab and implementing it in a clinical study. However, and I think every PhD student recognizes this, not everything went according to our plan. Some unexpected, interesting findings changed your course a bit. This led to a chapter about GP6 activated platelets inducing thrombin generation, the manuscript where you are most proud of, and that was accepted today. For this chapter, we had a lot of discussions with Flip and Mark, all of us giving you advice, suggestions for experiments, and helping you with your manuscript. I think they will all agree with me that you are very persistent and sometimes also very stubborn. Although you did not always make it easy for us, I do think these qualities are really valuable and will help you to become an independent scientist. In the beginning of 2020, thanks to the help of Mark and Joke, a new clinical study on multiple myeloma was set up. Together with Jatju, you went to Amersfoort to work in the Meander Medical Center on the TIM study. You were both enthusiastic as you could explore another part of the Netherlands. You were working really hard in the lab and gathered the first data in no time. Unfortunately, COVID-19 came and disturbed your PhD project. The inclusion of new patients was stopped, and it soon became clear that we needed to prepare a chapter with the data you gathered up till then. This was a big disappointment for you. Furthermore, due to COVID-19, we needed to work from home as much as possible. I believe this was an extremely difficult time for you, and I think I underestimated the impact the pandemic had on you. It was difficult to gain insight in your state of mind and to help you with your projects as we could not meet face to face. In the beginning of 2021, you decided to go back to China, and I supported this choice completely as I noticed that you were struggling. However, this decision did not change your commitment to your work. The last chapters of your thesis were finalized and manuscripts were submitted. And today, it's your day, Dr. Lee, the icing on the cake, your PhD defense. Lee, it was a pleasure to be your supervisor all these years, but I would also like to emphasize the role of Mark. I know from experience that it sometimes is not easy to be confronted with the most extreme forms of Dutch directness. However, without him, your supervision would have been incomplete and short-sighted. Lee, I'm very proud to be your co-promoter, and I wish you success in your future career, being a scientist or anything else you now consider for yourself. I'm happy that I am given a chance to be the first to congratulate you with obtaining a PhD title. Congratulations.
Thank you, Donna.
I'll be the second one who's able to congratulate you. Dear Dr. Lee, also on behalf of the Board of Deans of Maastricht University, I congratulate you with the honor you have acquired. I can say that during your defense, you got some tough questions, but I can tell you that the members of the committee were really very happy the way you answered them and showed that you have a broad view on the topic and are not afraid to say when you don't know something. And that's also a good characteristic of a scientist. I would also like to congratulate the members of the supervisory team, of course, your family, colleagues, and friends. And I hope you will have somehow a festive day in China. It's a pity you couldn't be here in Maastricht because we have a nice sunny day today for the first time in a long time. I hope it's the same in China, and I wish you really a very pleasant day. I would also like to thank the members of the committee for their participations and the time they have taken to judge the thesis and be present here online in this defense. And with this, I declare this ceremony to be ended.
Thank you, Prorector.